MenQ did a great job of setting the table for explaining why it's so important now to start manning scanner utilization and squeezing every ounce of the scanners that we can out of the process. I first need to let you know that this was an academic project, and as such, the University of Maryland likes to remind me that everything that I do belongs to them. I also have a grant, and I serve as the chair of the American Board of Imaging Informatics, and I'm a consultant for analytical informatics. So what is the problem? So one thing is, if you sit in the modality, if you're sitting in the control room, what is the challenge for getting more patients on the scanner? Well, it turns out it is crazy down there. It's like a train station. You've got all kinds of staffing issues. You've got all kinds of equipment issues. You've got to coordinate with patient transport to get them downstairs. You've got to get the radiologist for contrast management. Sometimes you need to get the anesthesiologist or nursing. You've got inventory issues with contrast and equipment. You've got very poor control over your patient. All of a sudden they show up at 11 a.m. from a clinic, and you have to try to get them out, get them not have to wait too long in the waiting room. And you've got a mixed acuity environment where all of a sudden you have a patient that's ambulatory, no problem, and then a patient that comes with their kids, or they have a lot of needs, and you have to have sedation or ventilation. And so if you watch what goes on, you go, wow, this is really complex, and it's hard to see that at a 30,000-foot view what's going on the ground floor for the operations of these incredibly expensive but incredibly marvelous devices. So I think what happens a lot of time is, as a supervisor, you really get stuck in the firefighting. You get in such trench warfare, it's hard to remember what happened even more than a week ago. All you can remember is the last disaster that happened to a patient that waited for 3 hours from 2 weeks ago, where the referring physician stormed down and yelled at you. And, of course, when the chair walked by exactly the time when the scanners were empty, and then they had to come and make a visit to your office to say, what are you doing? Or do you know how to manage your technologist? Why is the scanners empty? And, of course, patients are waiting too long, and the scanners are empty, and now you really have that pressure. And on top of that, you've got a long exam durations that are blocking the scanners because those crazy radiologists want to do these bizarre protocols now and have 4,000 to 5,000 slices per patient. And of course, CMS said, oh, by the way, your reimbursements, we're going to change the metrics for how we reimburse to you. And we had originally said you need to utilize your equipment 50% of the time. We're not going to change that. You need to utilize it 90% of the time. And so there's big things afoot on how we're going to be even reimbursed for this incredibly expensive and marvelous technology. And so we took a look at this problem and said, really, this is a problem for complexity management. There's a lot going on, just trying to document, trying to understand all the dynamics of the flow of how to run a CT scanner. And in many cases, management is clueless as to what goes on downstairs in this process. All they see is these metrics at the end of the month. They say, I'd like to move from 50% utilization to 52%, make it happen, and they've got no idea what that means or how to execute that into a plan. So we have a partnership with information visualization laboratories, and we've looked at this from a complexity standpoint. Can we use information visualization techniques to help us understand what's going on? Can help us see how can we learn from this environment to see how we tailor our staffing models? Can we identify recurring system failures? It's very hard to have a systems focus as a supervisor. You live patient to patient. Every patient is unique. It's hard to see these recurrent things that slow you down once a week. It doesn't even hit your radar. And can we also try to leverage some social media techniques to help people document and communicate some of these logistical issues? And so, interesting enough, information visualization has a long history of explaining a lot of complex things in really concise information. This is one of the greatest masterpieces of information visualization. It shows the 1812 disastrous Napoleon campaign for Moscow. It has the size of the troops as they marched towards Moscow, where they were, the directions they took as they started shrinking and having battles. And so they start showing you several pieces of dimensions of information at the same time. The army location, its direction, how it splinters, and as it gets to Moscow, and then of course immediately turns around, and then it also shows you the temperature that was going on. So it shows you and the width is the size of the army as they have such attrition and death until the final part where they're just racing back to Paris. And so it really shows you several different dimensions at one time, and this is the real art of information visualization. Can you help explain this complexity and help people understand this orchestration environment? And one of the fathers is Edward Tufte. He's a professor at Yale, and he has this term that I like called chart junk. Anything that doesn't have information should not be involved in showing the information at all, because otherwise it's distracted. As a matter of fact, his biggest foe he cannot stand PowerPoint in the least. He thinks it's the demise of the corporate world using PowerPoint. So we built a web-based system, blah, blah, blah. It uses Ajax and it uses MySQL database. That we actually feed from the RIS for our data, and I can talk about that. We actually do some RSS feeds, and this is what it looks like. It looks like a visual swimming lane diagram. So here's one modality here. Let's see if I can use the later. And it shows you the hours of the day. We're a 24/7 shop, so this is midnight, 1 a.m., 2 a.m., all the way through noon, and then on to 24. And this shows you the begin and complete times. That's it for the wheels in and wheels out of the room. It comes from the RIS. It's manually typed in by the technologist, for goodness sake. So there's nothing complicated here. And the color describes us what type of patient was it. Was it an inpatient? That's blue. Was it an ED patient? That's pink. Was it an outpatient? That's green. So we kind of see some of the dynamics of the flow of what's going on. So we just want to show, we were looking, can we make this into a John Madden post-game show, trying to help you remember what actually happened today and why things went so crazy, what things worked well, and when things didn't work so well. And so we actually combine them into groups now. So here's several MR scanners, because typically MR scanners and CT scanners come in groups. You've got a whole suite of them, and you manage the patients, you round robin them through from one to the other, and you have to understand that when one goes down, it's going to impact the other two. And so there's a lot of interdependencies in understanding the flow of what's going on in this process. And so now we are able to look at this process. So one of the things we are able to see is a couple of new colors come in, orange and red. Orange says the technologist documented that there's a delay associated with this case. And so a lot of this effort was trying to help the technologist to document why things weren't working smoothly, what's going on in the process. The red timestamps say, hey, this timestamp, the begin, overlaps with the previous studies complete. And so there was a mistake made. Maybe the technologist typed in something incorrectly. And so we were able to visually flag those and say, hey, can we have this effort to help change the behavior of the technologists to improve how they document these efforts? And so what's interesting, we came up with a very simple script. You're a supervisor. Your job is to do 3 things for 15 minutes a day. You look at this list. You look for any reds, and if you see any reds, you flag them, and we put it into our issued database that goes to the technologist report card. You look for any cases that took longer than they should have. And also, you look for any holes. Why was there no one scanned on MR3 between the hours of 11 and 1? It's just begging the question, why? And so this is a documentation trying to understand the stories behind what goes on with the flow dynamics. So we actually can hover over things and get details of exactly the story. I think it's really important in healthcare. We're all about trying to understand everyone's very different in their procedures and the complexity. We're getting back to the original story is very critical. So we get all the details. We can click on it and get the report and see what actually happened when the interventionalist was doing the procedure and trying to understand the actual details of the processing. We get all the timestamps to see some of the flow. And so we can hover over and click through. Also, the other thing we felt was, wait a minute. Well, this was empty from 11 to 1. How many patients were waiting in the waiting room at that time? What was the demand? We can't understand utilization until we can see, well, how much were you supposed to be doing? What was your queue looking like? And so here's a vertical bar graph. It's a stacked bar graph of the different types of patients. At 8 a.m., we had 4 patients that were waiting in the waiting room. This could be that they could be doing prep work, they could be doing other things. This chart's showing you the demand, that patient's ready to go. So some of the problems could be your ability to poorly schedule patients, and so understanding how you can get laminar flow. And I think what's interesting is we looked at this tool as a way to say, it's not just about trying to make them run like rabbits and do as many cases as they can. It's actually about laminar flow. Too much flow is bad, as well as too little flow. Those are both bad situations. What you want is laminar flow, where it's nice, consistent, less errors, stable work, and they're able to be as effective as possible without having to handle these peaks and valleys in what's going on. They're trying to understand. So now we can understand, well, wait a minute, there's not any outpatients during this time on the 3T. There's just the ED scanner and trauma patients. And so there wasn't an outpatient volume at that time. That's why there wasn't any patients scanned on the 3T. Another great key person in information visualization is Ben Schneiderman, and he has got this great mantra. He goes, the whole key to information visualization and understanding data is 3 concepts, or I guess 4. First, you want a big picture. You want to zoom out. At a glance, what's the big picture? What are all the cases going on today? And then you want to be able to zoom in. And then you want to filter. And you want to answer all these individual questions, and then you build up these patterns around that. And so overview, zoom in, filter, details on demand, and repeat as many times as necessary. So just going through this cycle of trying to understand this data helps you understand the patterns around what's going on. And so we started doing this. So now we have the ability to filter by our site, by our modality. We can compare our outpatient practice with our inpatient. It's kind of interesting. Our outpatient does a really good job of efficiency. It's harder to replicate that in an inpatient environment. We can see some of the dynamics around that. And so you can kind of start learning and sharing some of the best practices. And the most important thing we did, actually, we built this little tool for ability to blog. So the technologists can blog and say, here's what's going on at this time. We actually now have about 20 blogs a day coming out of our CT group. They blog like crazy now. I was waiting for the ED. They wouldn't bring their patient over. All my CT patients are drinkers, and I have to wait another half hour. They start telling you all the dynamics for what's going on to help you to become empowered management to actually understand what's going on in the complexity of operations. And this has actually been a great communications tool to try to understand the art of how to effectively manage in this environment. So we also can we can click on this patient queue graph here, saying at 8 a.m. we had 4 patients. What's up with that? And you can see here, this is a stacked queue graph. This is a very classic industrial engineering design for looking at the flow, where you see here the number of patients as they came in during the day on the bottom, going vertically. This is the patient procedure, and you see this patient came in at 1 a.m. and they were scanned by 1:30. The scan was completed by 3 a.m. The next patient came in and so on. What this shows you is a great idea of looking at the rate of arrival. Do they come in a stampede? Look, these 5 patients came almost within the same half hour of each other. Well, guess what? There's a rate of arrival and there's a rate of departure. How many patients can you handle per hour per room? Guess what happens if your rate of arrival is greater than your rate of departure? You have a bathtub. You start backing up. And that's exactly what happens here. We only have 2 scanners that they're using, and you can see they kind of start back up, and here these patients were waiting longer and longer until we were able to catch up, and the rate of arrival started flowing and evening out. So you have these areas of compression and rarefaction, and helps you understand and gives you a flow perspective around the art, if you will, of trying to manage your modalities. And so we also can do inline filtering where we say, well, what's going on with this procedure? Why is this procedure taking twice as long as it should have? And trying to get the details around it and really having a visual idea of how this is affecting your operational flow in the environment. And we found these have been very effective cognitive tools for helping our supervisors explain what's been going on. So the other great quote that I like, one of my role models, Supreme Court Justice Louis Brandeis: sunlight, an amazing disinfectant for social diseases. If you have behavioral issues, don't treat your technologists like you're trying to control them. You're actually trying to empower them and understand how they work, but at the same time, they now see themselves as entirely accountable. They're my biggest users of this tool, is in trying to understand their own environment, because it's hard for them to have an institutional memory, because there's such a day-to-day warfare going on in the trenches and it's hard to see this from a bigger picture. And this helps them see their big goal that they're trying to do over a longer period of time and seeing the bigger picture of what they do. Okay, so in conclusion, what's kind of interesting here, we've rolled this tool for about a year, and actually it's been very good for documentation and storytelling. Our chairman rarely yells at them anymore. Our supervisors are actually become addicts. They cannot live without this tool. And what's interesting though is we've looked at this tool. It's incorporated into our daily activity. I think that's the whole key with these tools. You have to have eyeballs. You have to have actionable information, people to be able to use that. But we have not seen a real solid increase in utilization. We can't say we've doubled our efficiency on our scanners. And what's interesting, so we said, okay, well, maybe we don't need this tool anymore. But we found that it has totally changed our staffing models for how we tailor. Even people who've been supervisors for 20 years said, oh, I just didn't really see that coming. And now I've tailored my staffing models to see how we drop off at 2 p.m. or 4 p.m. or how to handle the inpatient switchovers and things like that. And it has... we've really now been able to take a much more systemic approach at our failure modes, our delays, and trying to understand them from a systems perspective, see why they're happening, why we're not communicating clearly with our mobile patient transport team and things like that. And so in conclusion, it's actually been a very good tool. Everyone loves it in terms of relations and trying to understand the flow of our system. And it helps you start having that conversation for how to get as much as you can out of your modalities. Thank you.